Handle Your Business, a weekly podcast discussing a little of this and a little of that. Handle Your Business appropriately blends serious topics with fun topics, all in an effort to help you have a good or better life. So join me, your host, Lady Lashley, and some amazing guests every Sunday at 5 p.m. to explore everything from financial management to dealing with relationship challenges. Put it in your calendar every Sunday from 5 p.m. Tune in to Handle Your Business to get you ready for the week ahead. For more details, follow at Lady Lashley TT on Instagram and Facebook. Handle Your Business. Welcome to another episode of Handle Your Business with yours truly, Lady Lashley. Today we are going to be discussing female health, and I have with me Dr. Matt Myrie, specialist physician, surgeon, gynecologist, all of that good stuff. And we're talking about female health with respect to gynecology and that whole area that Dr. Myrie specializes in. So thank you very much, Dr. Myrie, for agreeing to join me. Welcome to Handle Your Business.
Many thanks and blessed wishes. Happy to be here.
All right, so jumping straight in, with respect to your own area of expertise as a physician and specialist, what would you say are some of those common areas affecting women in Tobago, Trinidad, and the Caribbean, as far as you're aware?
Our women will have to face certain challenges depending on what aspect and stage of life and development they are, where along that life trajectory they would pitch. So you have challenges that face pre-adolescent females, you have the teenage female problems, you have the adolescent, those in the reproductive age group, and those approaching menopause, at menopause and beyond. The various risks that face women at those stages would form the risk profile of what you need to attend to. So for instance, what would be pressing that would be covering from birth to maybe premenopause would be reproductive issues and aspects of lifestyle, well, preliminary poorly lifestyle habits that would make reproduction and reproductive issues a challenge in that time period. So, from example, menarche, which is the beginning of your menstrual cycle, hormonal issues can become a problem, primarily issues affecting your ovaries as common now, known as polycystic ovarian syndrome. It's an old disease that we have gained some knowledge on over the years, and it has improved the management of these clients. Other issues would include uterine fibroids that can cause problems with the menstrual cycle and reproductive potential. You have infectious diseases, pelvic inflammatory disease, commonly caused by organisms like Chlamydia and Neisseria gonorrhea. Those favor damage to the tubes and would cause problems with fertility, problems with ectopic pregnancies, etc. Beyond that, we may have hormonal issues stemming to other reproductive organs, for example, the breasts. Common benign conditions that would affect women would be something like fibrocystic breast disease. It's not a cancerous condition nor a precancerous one, but one that causes nuances with respect to pain and engorgement during the menstrual cycle or the premenstrual phase. And then you go to the malignant causes. Breast cancer is now on the rise. It's rising frequency and on the rise in the younger population. I've seen breast cancer now in late 20s and that was something that was rare up until the late 1950s. So that is a concern. Going into the perimenopausal age group, where a lot of women now are having children, as opposed to the traditional early 20s, 30s, a lot of career-oriented influences, other aspiration influences detract from the maternal instinct that would normally manifest at an earlier age is now coming on stream when women are having difficulties becoming pregnant and maintaining pregnancies due to a lot of medical conditions that would complicate the pregnancies. So that as well. And then, of course, you're moving into the age range where precancerous lesions will now start to plague tissue. In the perimenopausal, going into the postmenopausal age bracket, we now would be in precancerous cervix, which HPV infections, endometrial cancers, and the cancers of the ovaries and fallopian tubes, etc., in the postmenopausal age group. All of those conditions, and then in the advanced menopausal age group, you have medical conditions that stem from or get worse because of the actual process of menopause, whereas there was a protective mechanism when the estrogen was at its peak concentration in the bloodstream. Once that becomes diminished, it levels the playing field for certain cardiovascular related diseases to be more prevalent. Hypertension, diabetes, dyslipidemias, etc. So it's a whole spectrum, and osteoporosis as well. It doesn't affect the typical Tibigonian women as much, but it is seen occasionally, and it does cause health problems with mobility, respiration, stuff like that. So depending on your age group, depending on where you are in the stage of development and life, you'd have to contend with something of the sort as a woman in Tobago, the wider Caribbean region, or in fact, the wider world. So the tweaking in management will depend on where you are on the planet. The principles of management are pretty much the same, but the conditions that prevail at that particular point in time will dictate how we go about circumventing the risk factors and actually managing the conditions.
Okay. For each of these age groups, because there's several different presenting factors, how often should, based on your age group or where you fall in, whichever category you fall in, how often should women be screened or check with a doctor?
Okay. Frequency would depend on if the risk of whatever you're contending with is of a concern enough that it must raise the bar of surveillance outside of the norm. You can only make that determination by a clinical evaluation. So once that is done, then a plan can be put forward as to what should be done and how frequently it should be done. So that is actually personal. That would be an individualistic, and it would be individualized to the person. But in general, for example, something like a cervical smear, that traditionally was done annually.
That's the pap smear?
Yes, that's taking something out of the arbitrary bag. That was done, and pap smears were done, and some are still being done annually, and may even be warranted so, depending on the circumstances it's dealing. But in the ideal way, pap smears now have evolved from going from annually to biannually every 3 years and up to even every 5 years. But that will depend on the risk profile that you have, and it may be modified depending on lifestyle habits and environmental circumstances, etc. Those things would have to be fine-tuned with evaluations. So to cover everything else, for example, breast screening, maybe screening for cardiovascular illnesses, I would say you'd have an initial clinical evaluation first, and then if everything is normal and we're just doing preventative measures, at least an annual checkup would suffice. If you have risk factors that would make it a bit more concerning, you might have to have biannual surveillance. If you have a disease process going on and you're embarking upon treatment now, and you're monitoring resolution or recurrence or relapse, then you'd have to increase the frequency to probably quarterly.
Oh, okay. With respect to the young girls, because you mentioned the teens earlier, younger girls, they can't decide, but I guess for their parents, mothers, etc., what's the earliest age you should take in a teen who doesn't necessarily present with anything, but maybe you want to do some kind of basic checkup? What's the earliest age to take a young girl to be screened or to be seen by a doctor?
If it's just for routine check, without any predisposing illnesses or so on, you could start when they becoming into the adolescent age group, like 12 and onwards. That would get them into that habit forming early, and get them to have an appreciation of the stage of development that they are, because usually that is surrounding a lot of changes taking place. Some may not have the benefit of teaching or explaining what may be happening. Even the parent may benefit from that exercise as well. So I would say 12 years old for just routine, and then you probably can follow up every 3 years after that.
Okay, so but just as an aside with that, there are some girls, I know you link it sort of like with the start of puberty. Is this linked specifically to any particular part of puberty, given now that some girls are developing breasts at age 9, age 10?
Well, 12 would have been somewhere around the conclusion of or in the middle of puberty. In fact, while it seems to be getting earlier and earlier, 9 and 10 is not so bad. I mean, we accept up to 8 and 7, depending on ethnicity, before we call it precocious puberty. But it would fall in the process of puberty, because then you can have delayed puberty anywhere after age 15, 16. So you just find a ball point to meet them at that stage of development and start their preventative medicine trod. So it's just an average that should catch with most females within that phase of development.
Okay, and what would like a very basic general checkup for that age group for a young girl look like? Because we're in a society where people have all sorts of interesting thoughts around checkups and that kind of thing. So like for parents who are listening and maybe considering bringing in their daughter, what can they expect in terms of what a general checkup may look like for that age group, 9 to 12?
All right. Well, to begin with, they would have to be accompanied by their parent or guardian who would be present at the interview, And the evaluation would include taking what you call a medical history, which would go as far, if it's involving the child, it would include the mommy's pregnancy, if the mommy had a complicated pregnancy, and if so, what was it and what was done, etc. How would it influence the baby at birth and subsequent development? The home environment is critical, the developmental milestones, if any childhood illnesses, immunization history, allergies, basic coverage like that. The physical part would include general examination of the skin, whatever secondary sexual characteristics would have started to develop. You would have breast budding at least. There'd probably be at a time of stage 3 or 4. And it could include ENT, respiratory examination, the cardiovascular system, the abdomen, the musculoskeletal. And if we need to examine like the state of the ovaries, if they're having problems with the menstrual cycle, some would be displaying hirsutism features. So you'd like to know the state of the ovaries. That would have to be accessed with imaging. And then the imaging modality would most likely be the one used on the abdomen, with the bladder over distended with urine. Most would not be sexually active, so a transvaginal probe would be contraindicated in that population mostly. And also a cervical smear would be contraindicated once they're not sexually active.
Right. Okay. So once they're not sexually active, there will be no sort of penetrative testing of the vagina. With respect to the girls who are menstruating, because this is linked also to possible pregnancy, whether or not they are initiating sex on their own, being molested, or whatever it is there a particular age group or age restriction with respect to birth control for menstruating girls?
No, there isn't. The contraindications wouldn't be based purely because of age. In fact, a lot of the emergency contraceptive measures are used in that age group. And adolescents as well. The use of contraceptives would definitely be for pregnancy prevention, whether they had a pregnancy before as a teenage pregnancy and then you want to prevent another one, or other circumstances would include the parent discovering that the child is sexually active or at high risk of it, and then voluntarily want to have a contraceptive put in place to prevent the eventuality of the pregnancy. You have the ones with the pill and with the inserts. The intrauterine contraceptive device is one of the methods used for both contraception, and then you could leave it in to serve as contraceptive long term.
Oh, okay. Is that's common in the Caribbean, in Tobago and the Caribbean?
You mean using the IUCD like that?
Yeah.
I wouldn't say it's common, but it's used.
It's used. Okay. The other aspect of contraception, I know a lot of women, young girls who are into sports, who are athletes, I guess as a way to control or stop their period, they tend to be on birth control for that purpose. is that something that's healthy, favorable, that kind of thing?
I would avoid that on several fronts. One, if you're speaking strictly of athletics and athletes, there is a proportion that may not respond favorably with respect to something like even weight gain. 1 in 5 will experience weight gain, and that might be not conducive for them athlete aspirations. 2, it may be a conflict of interest when you're talking about drug screening. There's some that may be testosterone based. For example, the contraceptives that are used to treat PCO, and there are strong hirsutism features that may create some confusion with drug testing, or that's a possibility. And there are other medical contraindications that may make it not. If there's risk of diabetes or gallstones involved, if there's sickle cell involved, you have some athletes who are sicklers now. If you have a strong history of hypercholesterolemia problems, those are genetic problems, or secondary hypertension, you wouldn't want to use contraceptives, at least the hormonal preparations, in those circumstances. So barring those things, it would be, again, individualistic, and you'd have to look at the entire picture of that athlete before you make a choice like that.
Right. Okay. So I'm guessing the parents of such athletes, they should perhaps consult with a doctor, consult with a physician, get a second opinion on that, because of all of those possibilities.
In fact, anyone going on contraception for the very first time should be monitored by a physician for at least a minimum of 6 months.
Oh, wow. Okay.
For the very first time. After that, then you can go on your own. So that's the ideal. That's the monitor response and any side effects, etc., stuff like that.
Okay. As we on the contraception still, and you talk about the monitoring, it reminded me now the birth control injection. Oh, the famous birth control injection. That injection has some interesting, and possibly I could call them wicked, side effects. What I discovered recently is that there are many women who choose to go on that birth control, but the injection causes a lot of bleeding. So just recently I was asking 2 women, I said, if you go on the birth control with the purpose, with the intention to have unprotected sex, no condoms, that kind of thing, but you're just bleeding down the place, how does that work? But I'm saying that to ask you, is there another way what are the birth control options that don't have these gross side effects for women in particular, or we don't have any?
I suspect you're speaking about the progesterone only injectable contraceptive known
Depo. I don't know what it is.
Okay, because you have the combined injectable as well. But the one you describe is the progesterone only. That one is suitable most of the time. 8 out of 10 of the times, women will have a favorable response with it, meaning no weight gain and no withdrawal bleeding, which is what you described. Now, the withdrawal bleeding would result from when there's fluctuation in the concentration levels of the hormones that would be in the bloodstream at the time. And various factors would influence that. The technique of the administration and the injection, is a factor. It's an intramuscular injection, and so it must be deposited within the muscle tissue for optimal absorption into the bloodstream. If oftentimes it can be deposited in the which has an inferior blood supply, you may have erratic absorption from the fat cells. So where it's placed is for the best response. That's one factor. You may just not have a reason to it properly. And that affects 20% of women to the point where they would have to discontinue using it. Once we make sure that there are no other reasons that you may be bleeding other than that, then press on and see if, having corrected all of the variable factors that would give you withdrawal bleeding, continue and see if with time you would adjust to a more favorable state where the bleeding might be not so prevalent, or it may revert to what you would expect it to be, which is either your periods will remain as is, or they would be lighter, or what most women would prefer, they would become absent. Sometimes we may have to supplement the medication that is given in the muscles with oral medication to control bleeding, and women may end up having the injection by the injectable route, and you may have to supplement it with oral therapy as well, just because you have withdrawal bleeding.
Oh, okay, cool. I guess at the end of the day, it's talking to your doctor and finding out what's workable for you as the woman. The time is running away with us, but I have a few more questions. Earlier, you mentioned in one of these stages for the woman, you mentioned one of the factors being, I think, brought on or facilitated by chlamydia and gonorrhea. I thought those were long ago diseases. Those still exist? As in, they're still common?
Well, they're still common. The only difference is chlamydia now has the lead over gonorrhea in claiming tubal disease morbidity. In the early, like before the 1950s, gonorrhea was more prevalent.
Wow. Okay. What's a sign? How can someone tell if they might have that and need to check?
The problem with chlamydia, something like chlamydia, you may not have any symptoms. And if you do, they may not even clue you into anything serious. You may have a clear discharge, and that may be it. You may even be what they call carrier status, where you're absolutely asymptomatic. However, you actually harbor the microorganism within your tissues. Most of the symptoms related to chlamydia would be once it has done its due course damage, which is the tubal anatomy on the inside, where the cells that line the tubal duct, where the egg passes to meet the sperm, and then once fertilized, it gets swept back to the endometrial cavity for implantation. That is where the chlamydia would do its damage, and symptoms associated with that part would be pain. You may have pain with movement of the tubes, so sex may be painful. You may have misplacement of the pregnancy, meaning the pregnancy may get trapped in the tube. So a symptom would be an ectopic pregnancy, and then the complications thereafter. You may get what you call a complication as pelvic inflammatory disease, where the stage is set for other microorganisms to have a party, and you get a rip-roaring infection with fever, pain. You may have other features like diarrhea, vomiting, and those conditions would be treated depending on the presenting symptoms. So antibiotics for infections, you may have to have surgery in some instances of complicated infections. Ectopic pregnancies would require either medical therapy or surgical therapy, depending. And then the minor symptoms, we would probably investigate, depending on how astute the clinician is. You may want to screen for sexual transmitted infections if you suspect that they may be present. And then if present, then you initiate what they call contact screening, meaning you track down other partners and test them and treat them as necessary as well.
All right. Very interesting. I guess my takeaway here is make sure and get your annual routine check and ask all the questions and see about all the different tests that you may need to do, all the different screenings that you may need to do. That contact tracing in a society like ours, you might as well just put out a notice for everybody to come and screen.
Right.
And that's another thing by itself.
That one is quite common here, the chlamydia.
Wow. I learned something, Dr. Myrie. I definitely might have to ask you to do this again with me because we're out of time and I have so many more questions. I mean, we didn't even touch a lot of the things, but I want to thank you.
Part two.
Yes. We definitely have to do a part two. In 1 minute, any closing parting words for the women who will listen to this, and even the men, because some of the men need to know what's going on with their female partners, so take a better interest. Any closing remarks in 1 minute?
Well, listen, while you focus on the exclusive female features of health and healthcare, health the broad being of the female. So we're speaking about wholeness from all the 7 aspects of your existence coming together in a balance to give you optimal health. So we're speaking of your spiritual well-being, we're speaking of your physical well-being, your procreational well-being, some of those aspects we touched today, your psychological well-being, emotional well-being, your economical well-being, and social well-being. It would have to be a balance with all of those aspects to have the right mix and fit for a healthy life for our women and men as well.
All right. Well, thank you very much. We had the conversation. So whoever is listening, handle your business. All right. Just handle your business. Thank you very much, Dr. Myrie.
The literal and the figurative business.
Thank you. Handle Your Business, a weekly podcast discussing a little of this and a little of that. Handle Your Business appropriately blends serious topics with fun topics, all in an effort to help you have a good or better life. So join me, your host, Lady Lashley, and some amazing guests every Sunday at 5 p.m. to explore everything from financial management to dealing with relationship challenges. Put it in your calendar every Sunday from 5 p.m. Tune in to Handle Your Business to get you ready for the week ahead. For more details, follow at Lady Lashley TT on Instagram and Facebook. Handle Your Business.